This is wonderful. Great to see everyone today. Looks like we've got a
Mm-hmm.
great representation from across the country. This is great. Actually, from across the globe, actually, we have quite a few people.
Mm-hmm.
So, for those who just came in, I just admitted a few more. We are in the chat at the moment, and we're just kind of letting everyone know where we're from, what our name is, what our role is, and what brought you here today. If you have any questions, feel free to pop them in the chat, and we will be sure to address those at the end during our Q&A section. It is 1:05, so I think to be mindful of everyone's time, we'll go ahead and get started. So welcome again to today's session. This is the final session of our series, Taking the Pain Out of Pain Management One Step at a Time. And today we'll be discussing the total concept of pain. And for those of you who are new to the series and to ECHO with the North Simcoe Muskoka Hospice Palliative Care Network, my name is Amanda Tvelda, and I'm excited to have you here with us today. And before we begin, we would like to acknowledge that the land in which we are gathered on today is a traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of the Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and most recently, the Mississaugas of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited to this covenant in the spirit of respect, peace, and friendship. Most of us here come as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And as most of you, or you're probably all aware, we are here today for the Palliative Care ECHO Project. This is a 5-year national initiative to cultivate communities of practice and establish continuous professional development. So thank you for joining us. And this is partly in thanks to the financial contribution from Health Canada. Without their financial support, the Palliative Care ECHO Project would not be possible. And the production of the presentation has been made possible through the financial contribution. And the views expressed here on in do not necessarily represent those of Health Canada. They are of the North Simcoe Muskoka Hospice Palliative Care Network. Now for the fun part, I get to hand this over to my colleagues, and today's presenters are Kathleen Bartlett and Laura Bates, who will be discussing the concept of total pain with you today. The floor is all yours, ladies.
Thank you, Amanda. So I'm going to get us started today. Just a reminder, if you've got a smartphone nearby that can read a QR code, there's a survey to complete once you've watched the presentation, and it will also be included in the email that goes out afterwards in case you want to wait to do it till then. And Amanda has also put the link in the chat. So today, by the end of our session, we will expect that you'll be able to define the concept of total pain, use validated tools to assess total pain, describe how physical pain, spiritual pain, emotional pain, and social pain are connected, and describe the barriers that can be presented for assessing and treating total pain. So let's do a quick review of what we've learned so far about pain. Pain is one of the most common and distressing symptoms that is described by patients. It leads to a compromised quality of life for those who have serious or life-limiting illnesses, and suffering from pain has a detrimental influence on one's expectations and hopes for their future. A reminder that pain is a multidimensional symptom. an unpleasant emotion or sensory perception that's shaped by the disease process, underlying psychosocial suffering, and past experiences that a patient has had with pain and its management. Pain is always subjective and is always whatever the person says it is. And we need to be mindful of the variety of terminology or language that patients use to describe and explain their symptoms and their experiences, because that will help us better understand how we can help our patients. So thorough assessment of pain is required in order to determine the probable causes and best choices of intervention. And patients who are not able to verbalize or are unresponsive for whatever reason require the use of a specialized type of pain assessment, and we will review that later. Pain can be controlled through both pharmacological and non-pharmacological interventions, approximately 85 to 95% of the time. Despite this, poor pain control is still a leading cause of suffering in those who are receiving a palliative approach to care or who are at end of life. So what exactly is total pain? And it's not something that you often hear about in your education unless you are looking into some of the more psychosocial domains. So this diagram is a good reminder that until we know exactly what kind of pain somebody is experiencing, we aren't able to intervene in the most appropriate manner. So we need to know whether the pain is acute or persistent, malignant or non-malignant, and if it's neuropathic versus nociceptive, whether it's somatic, visceral, peripheral, or in the CNS. Dame Cicely Saunders once said, "A cry just to be rid of pain is not worthy of man. Man by his very nature finds that he has to question the pain he endures and seek meaning in it. And it is this medicine which also allows the yoke of materialistic values to be broken by an approach to suffering which sees in its opportunity for the finest sentiments, human sentiments, to shine through." She was the first who used the term total pain. It stands to try to explain that multifaceted nature of the pain experience in a patient who's receiving a palliative approach to care. The concept of total pain should be a way of standardizing the definition for pain interventions and evaluations for all patients who are receiving hospice palliative care. Often the other domains in a person's life are overlooked, and therefore treatable suffering can be missed or inappropriately medicated. Pallium Canada also includes the definition of somaticizing when they speak of total pain. And that is a phenomenon where a patient may be experiencing and expressing pain, but the mechanisms of that pain do not appear to be due to the physical or physiological damage that's caused by the disease itself. So that's when we have pain that just is not matching what we would expect from that patient due to their disease. The concept of total pain is a reminder that good hospice palliative care provides and uses a holistic approach for symptom management and prevention in order to support the best possible quality of life for the patient and their family. Dame Cicely Saunders also spoke about this in her writing Into the Valley of the Shadow of Death, which was published in 1996. She wrote about how the experiences, beliefs, hopes, and fears of each person are reflected in how they live and in how they die. The patient does not only experience physical symptoms from their disease process, but emotions, fears, concerns for family or friends that will be left behind and bereaved. And also, it entails the search for meaning in their situation and their experience. So as we alluded to, there are 4 different areas which make up total pain, and I'm going to discuss the first 2. So they are physical, social, spiritual, and emotional. So this diagram shows some of the ways that total pain can be expressed in the spiritual, emotional, or social areas, and shows how all 4 areas are interconnected. Unaddressed physical pain can be the cause of social, spiritual, or emotional pain. And if there is unaddressed spiritual, emotional, or social pain, it can manifest as physical pain, which does not respond well to typical interventions. And you can see from the diagram some of the signs for each of the areas that there might be unaddressed pain. So let's go into this a little bit more detail. It is vital as healthcare providers that we are continually assessing our patient and their family across all domains of illness in order to appropriately manage and treat for symptoms they are experiencing. Total pain is evident in the suffering of those with serious or life-limiting illnesses because of how these components are intertwined. An example of how this would work could be seen in a patient who is nearing end of life. They have a loss of hope due to their illness advancing and no longer responding to treatment. This leads to involvement of both the spiritual and psychological domain, which then in turn could increase the physical manifestation of their pain. As suffering continues or even increases, it impacts those who are caring for them and around them, as those people will feel helpless when they cannot help relieve that suffering. This can cause people to distance themselves, which then impacts the social domain of the patient. And you can see how that would continually cause more and more suffering. So first, we're going to focus on physical pain. And just a reminder, in our previous sessions, we went into great depth of detail on the assessment, intervention, and management of physical pain. And Amanda will be putting a link in the chat to those previous videos if you were not able to attend those ones. So we're just going to do a brief touch on physical pain today. No matter which validated tool you choose to use to assess the pain of your patient, you have to ensure that it is appropriate for your patient and ensure that there is consistency between assessments and amongst the healthcare providers doing the assessing in order to best track the presence of pain and your interventions. As with all assessments, ensure you are using open-ended questions to promote conversation and the sharing of information between the patient and the healthcare providers. When intervening and managing physical pain, ensure you are following the WHO 3-step analgesic ladder and including adjuvants as appropriate for the situation. Also consider the use of non-pharmacological interventions and ensure that all medication side effects are well managed also. Also consider if your physical pain is not well managed, that there might be a non-physical source of the pain. So what exactly is social pain? Social pain takes into account all of the patient's extended family and friends, basically anyone who comes in contact with them in their life, and what they mean to the patient. It also takes into account the patient's thoughts and fears of the what-ifs that are involved in their care and after their illness and death. So this may show as fear of dependency or losing their previous level of independence. This might express as loss of role within relationships or within the community. This might be expressed as a loss of dignity or self-worth. It could come out as a fear of the unknown in regards to what will happen when they require more care or as their illness progresses. And it may be expressed in practical or financial issues or concerns also. So the need for social relationships is more important to most patients than their own emotional needs. They strive for a sense of belonging, and this may become more apparent as death becomes closer. Social pain is often related to everyday issues such as housing, family relationships, finances, and the social aspect of total pain can be shown through discomfort by discomfort of one's own thoughts that something will impact their loved ones, such as distress or harm or pain. This is why it is very important for healthcare providers to know who a patient wants to have involved in their circle of care, as well as their perception of assessing pain, especially for those who cannot speak for themselves. It is important to have discussions around social factors and possibly involving someone like a social worker to discuss things like relationship stress, finances, school, career, children. This also allows family members or loved ones to express their own feelings and fears, which in turn leads to better support and understanding amongst all that are involved. And this slide is just a quick reminder of all the types of questions that should be included in a thorough psychosocial assessment, and it is not inclusive. This would be the bare minimum that would be involved in a good assessment for social pain. So you're looking at the patient and their family's thoughts, feelings about illness, treatment, and care, how they're coping with emotions, changes in function, symptom management. Are there any cultural influences or social contexts that need to be taken into account? What is their lived experience of their illness, how they feel it's impacting themselves, others, and what they consider quality of life. It looks at suffering and the existential or spiritual domain also. And as before, it can address financial or practical needs and concerns also. So in order to intervene and manage social pain, all who are involved in the patient and family care should be able to provide supportive counseling to some degree. If necessary, consider referring to social work and/or a therapist, depending on what's available in your area. Consider linking patients and their family to organizations who support people with that specific disease, such as the Alzheimer's Society or the ALS Society or Cancer Society, so that people are getting that lived experience support from people who've been in their shoes before. Also, to help with social pain, we would encourage people to do legacy work and memory making, encourage the maintenance of social connections instead of withdrawing. And depending on your role, healthcare workers of a variety of disciplines can help with paperwork required for financial or practical assistance, or refer to somebody who can do those. So now I'm going to hand it over to Kathleen to go over the other two areas.
Thanks, Laura. So next we're going to be discussing spiritual. We can go to the next slide. So what is spiritual pain? It's despair from the inner realization that life is finite, loss of previous definition of meaning of life, feelings of abandonment or disconnection from a person's community, deity, or higher power. It involves questioning the meaning of life and/or the dying process. It does not always involve organized religion and can sometimes be described as soul pain. Although there's no universal definition that applies, it's a multi-dimensional concept. It can be one's connection to God, sometimes a higher power, a deity, a spiritual being. It provides faith, meaning in life, hope, and gratitude. It allows someone to find peace, self-identity, connectedness, inspiration, and allow for reconciliation. Spiritual assessment is very rarely done and often overlooked. Distress spiritually can be seen as physical, psychological symptoms that can often manifest. Spiritual needs can be assessed by asking patients about the meaning or the purpose in their life, how we can help them to find peace of mind, allow them to find forgiveness and acceptance, show love and be loved, allow them to request help, assist them in finding spiritual resources that they may request, and you can also help asking them what a good death would look like to them. A good idea is also to use open-ended questions, as Laura had mentioned, such as, are there things we need to know about your faith or religion, your spirituality that may help in providing care? What things give you meaning in your life? Or if they're a part of a specific religious or spiritual community, how can we reach out to those people? Some clues can include a person's lack of response to pharmacological interventions we would normally introduce for pain management. And these patients could experience profound emptiness, disconnection, abandonment, or have feelings of anxiety, or maybe not having God or their higher power around them. And they could also express words of why me. The assessment of spiritual pain. So we would assess for outstanding spiritual needs by asking questions about the meaning again or purpose in their life and what gives them strength. And some of the more commonly used tool is the FICA, which we'll go into a little bit more detail. And some others include hope, let go, faith, spirit, fact, or FFFF. So the FICA tool, the acronym here is at the side. So F is for faith, belief, and meaning. So some of the questions include, do you consider yourself a spiritual or religious person? Do you have any spiritual beliefs that help you cope with the stress? If that patient responds no, you could also ask, what gives you your life meaning? Is it important to contextualize these questions to the reason for the visit? So is it more for wellness, stress management, breaking bad news, or is it end of life? Meaning may be found in family, career, nature, arts, humanities, or other spiritual, cultural, or religious beliefs and practices. I stands for importance and influence. So what importance does your faith or belief have in your life? Have your beliefs influenced in how you handle stress? Do you have specific beliefs that might influence your healthcare decisions? And if so, are you willing to share those with your healthcare team? C is community. Are you part of a spiritual or religious community? Is there support to you and how? And is there a group of people who really love or who are important to you? Sometimes a good thing is to ask people like, who would you call at 2 in the morning, 11 o'clock at night, and just have those lists of people available to you. A is address or action and care. How should I address these issues in your healthcare? Who would you like to talk to someone about these matters? Would you like us to arrange for a member of your faith community to come and see you? This is also a reminder to clinicians to develop plans to address patients' spiritual distress or other spiritual issues. So for spiritual pain interventions and management, we could provide supportive counseling, refer to chaplains, social work, or a therapist. We can also encourage the patient and family to facilitate the use of clergy, religious leaders as appropriate. Again, as Laura mentioned previous, we could do legacy work and memory making and have the visiting hospice volunteer, if that's available in your community, come. So next is emotional. What is emotional pain? So psychological pain can be expressed in feelings of guilt, anxiety, depression, insomnia, or anger. They can also be seen as reactions of disbelief, emptiness, or numbness. And in one study through the Journal of Hospice and Palliative Nursing, it noted in a research article, it was shown that psychological suffering can lower one's pain threshold. So by being aware of your patient's emotional state or psychological needs, it can help us to treat appropriately, which may entail just sitting and listening to that patient, or maybe involving more specialized services such as psychologists. Ask questions, sit at your patient's level, have that open body language, and actively listen and participate in the communication. So these are just some of the descriptors for what emotional pain may be seen in your patients. So it could be seen as a feeling of hopelessness, despair, or helplessness, anxiety or depression, difficulty adjusting to changes, disengagement from care or excessive control over care, and a poor sense of well-being even when symptoms are well controlled. So for assessment of emotional pain, we could again use validated screening tools for depression and anxiety. These may require referral to psychiatry. Some of the tools for depression would be the Beck Depression Inventory or the Patient Health Questionnaire. And for anxiety would be the Patient Health Questionnaire or the Generalized Anxiety Disorder Screening tools. So emotional pain interventions and management, we would provide supportive counseling, have that referral again to social worker, a therapist, chaplain, or religious leader. Look at their medications, if they're on antidepressants or anti-anxiety medications. We could also use non-pharmacological interventions for depression and anxiety, such as cognitive behavior therapy, exercise, if they're able to do that. Try and improve their sleep habits and diet. And then there's also alternative therapies like reflexology, aromatherapy, acupuncture, or herb and supplements. We also want to ensure that all of their physical symptoms and medication side effects are being addressed. So are they having nausea, vomiting, difficulty breathing? Are they having any bowel issues, and making sure that those are managed? And we also want to ensure that all comorbidities, physical and psychological, have optimal treatment. So some of the barriers, management, and considerations in total pain can include stoicism, the inability to communicate, or cognitive impairment. Patients use different languages or terms to describe pain that the healthcare provider may not be familiar with, so having an interpreter available, or even sometimes a Google app, if that's allowed at your workplace, to use would be helpful. Healthcare providers can conduct the assessments, are not trained on how to use these tools properly. Some may rely strictly on their own observations. This, however, does not allow the person to describe their own feelings of pain or how their other domains are being impacted. And then there's also the fear and myths around the use of analgesics or adjuvants, like addiction or having the negative side effects. There was a note in a journal article understanding the concepts of total pain, and it said that pain is manifested physically, can be caused by the combination of maybe a child not visiting, somebody feeling despondent, or feeling that God has not left them. God has left them. And sometimes if they've got bed sores while they're in a hospital, those are all just different concepts of what somebody may experience as total pain, and that can be a barrier for us as healthcare providers to manage that. In terms of managing social pain, there is a lack of a trusting relationship with the healthcare provider or with the healthcare system in general. Patients may not be able to communicate their needs. So again, just having those resources available, like a communication board, patients who may not have someone to speak of who they are or who they were, fear of getting into trouble. So maybe having child welfare authorities involved if they're afraid of losing their house and their job, or even friends by accessing. Healthcare providers who do not use a trauma-informed approach, and healthcare providers who do not believe that their scope of practice includes psychosocial domains, are all barriers to managing social pain. Some of the barriers to managing spiritual pain, just be aware of your own feelings while you're managing these symptoms. Sometimes we can react emotionally, and these feelings may lead to avoidance of patients, a bias, or can impact the patient's overall treatments of care. One study provided in the Pallium Pocketbook, 2nd edition, noted that 15 to 20% of people do not want clinicians exploring their spiritual beliefs. Patients rarely voice the concerns of spiritual pain. Healthcare providers are also uncomfortable or untrained, or may hold biases again. And differences in religious, spiritual practices between the patient and healthcare providers may be present as well. Some of the barriers to managing emotional pain can again include stoicism, anger, hostility, withdrawal. Patients may mask their true feelings. Incorrect belief that dying patients must be anxious or depressed and all require treatments, or the incorrect belief that because the patient is dying, anxiety and depression are normally expected outcomes and do not require treatment. Some cultural considerations in the management of total pain. So cultural stereotyping, assuming a person will act a certain way in regards to their pain experience and management. So we can use more open-ended questions again. What do you call your pain? Do you have a name for it? What do you think has caused your pain? Why do you think and when do you think it started? What does your pain do to you? How does it work? How severe is your pain? Will it have a long or a short course? What's the most important result you hope to receive from treatment? What are the main problems your pain has caused you? And what do you fear most about your pain? So by asking these questions, it allows that open communication and building that trusting relationship. Skills that enable effective and appropriate communication interaction with people of other cultures requires that you be aware of your own cultural and family values, be aware of personal biases and assumptions about people, values different than your own, be aware and accept cultural differences between yourself and your patients, understand the dynamics of difference, adapt to and respect and be diverse. So, trauma-informed care shifts the focus of the care from what's wrong with you to what happened to you and provides a more complete picture of a person's life situation, both past and present. The principles of trauma-informed care include safety, trustworthiness and transparency, being open and honest with that person, peer support, collaboration, empowerment, and humility. So just to expand on those a little bit, safety, it gives the patients and the staff, they feel physically and psychologically safe to share information. For trustworthiness and transparency, decisions are made with transparency with the goal of building and maintaining that trusting relationship. Peer support can be individuals with shared experiences are integrated into the organization and viewed as integral to the service delivery. Collaboration is power differences between staff and clients and among organizational staff are all brought down to the same level in order to support a shared decision making. Empowerment, the patient and staff strength are recognized, built on and validated, and this includes the belief in resilience and the ability to heal from previous trauma. And finally, humility and responsiveness are the biases and stereotypes and historical trauma are recognized and again addressed. So the Total Pain Dream Team. I'll hand it over to Laura. You're muted, Laura.
There we go. I thought I had clicked it. I was saying, thanks, Kathleen. Let's talk about the dream team now. So in the perfect world, in the perfect setting, no matter where you are delivering hospice palliative care, you would have these people and more as needed to help you deal with a patient or a family's total pain experience. So this is not an inclusive list. This was as many as we could fit without making the font too small for you guys to read. So on your team, you'd want to have a variety of medical professionals such as physicians, nurse practitioners, disease specialists, nurses, PSWs, pharmacists, respiratory therapy, speech and language pathology, dietitians, social workers, and then you'd also want spiritual leaders, whether it's chaplain, clergy, religious leaders, community members from whatever community your patient is a part of, elders, traditional healers, or traditional medicine people. Also looking at adding in occupational therapy or physiotherapy. The list is infinite. If it could help in any of those four areas of total pain, they should be included. By accessing and involving members of an interdisciplinary team, however, it ensures that the approach is multifaceted because some disciplines may notice something that another discipline doesn't necessarily pay attention to. By including an interdisciplinary team, it allows for the best possible care and management for that person and their loved ones. So, to get you guys thinking a little bit more about this, we're going to do a couple of case studies. And feel free to unmute yourselves and talk, or to throw your answers into the chat as we go through the case studies and ask questions about them. So this first case study is about Joe. Joe is a 14-year-old male with T-cell lymphoma who has been hospitalized after developing chest pain and severe dyspnea. Further testing finds evidence that he has new tumors and that he also has a large pleural effusion. The pediatric ward is at capacity, so he is admitted to the adult floor in a ward room. Joe's parents have met with his medical team without him and are given his poor prognosis. His parents make the decision not to inform Joe of his prognosis at the time until his pain and dyspnea are better controlled. The next day, the person in the next bed suffers a cardiac arrest and dies despite CPR. In the commotion, no one thinks to move Joe, and he ends up witnessing most of the code, including CPR, intubation, and defibrillation. This is the first death Joe has ever witnessed. Joe is traumatized and alternates between needing sedation for inconsolable screaming and crying and being withdrawn, quiet, and apathetic. He expresses to his family and the medical team fears of dying and believes that what he witnessed is how everybody dies. He refuses to call any of his friends and refuses to do any schoolwork or participate in hobbies. Joe frequently questions his disease status to his medical team and to his family, wondering about the connection between his symptoms and whether his disease has returned. He expresses that his life is meaningless now that he is unable to play on his soccer team, hang out with his friends, go to youth group at church, or go to school. So what are some of your initial thoughts about Joe? Do you think he's showing signs of total pain? I see some absolutelys in the chat. Good.
Yes.
Yeah, definitely is. So where would you begin your assessment with Joe and his family?
Good support
Kathy
person.
says he needs a good support person to talk to. Yep, exactly. So let's think about who we would bring in to help Joe and how we would assess his needs first. Do you think something like the
Like
FICA?
participatory?
Yep, somebody wants to know whether he has any religious beliefs that we should consider. Yep, maybe a social worker. Ah, the youth pastor, yes. We know he already has a connection to a religious community. So if he's got a previous relationship that's trusting with somebody from his church, definitely bringing in the youth pastor or maybe the youth group person, getting his best friend involved for sure. Do we need to pay attention to all 4 of the areas for Joe, or do you think it's just 1 or 2 specific areas we should talk about with him? Good job. I see some people saying all 4 areas. That's right. Because they're so intertwined and interconnected, we need to make sure we're addressing all of them. And it can be a bit daunting to address all 4 at the same time, but that's why you bring in that interdisciplinary team. And I saw somebody commented that it might be hard for his friends to see him like that. And that's true. Yeah. You definitely need to tread gently in involving other young people just to make sure that everybody who's involved is being cared for appropriately. Good. So you guys got that. Any other thoughts on Joe? Who else could we bring into his team to help with his total pain? Good job, Kathy. We need to support his parents also. That's right. So his parents made the decision not to inform him about what was going on with his disease, and he's questioning that. So we need to have a discussion about how to go forward from that. Somebody said to rebuild trust, definitely. I can just imagine if Joe has never witnessed anybody dying before, and that's what he expects everybody is going to die like. Yeah, we'll have to make sure we've got the person who's giving the most care involved. Nicole, I would bring in somebody that specifically can speak to the trauma of seeing someone else die, because we know how crazy that kind of situation can be. And obviously the focus was on that patient and not on Joe being in the room. But I think somebody who has some specialized ability or some experience in trauma would definitely be helpful in helping Joe work through what he saw and what that might mean for him. Any other final thoughts before we move on? Okay, so we're gonna go to the next case study. But first, we're going to talk quickly about sort of the textbook answer for Joe. So for physical, we're going to make sure we do a full pain assessment to make sure that the pain of his disease process is managed appropriately, using the WHO ladder and titrating his analgesics and his adjuvants as needed, and possibly going back to oncology to see if additional chemotherapy or similar treatment might be indicated. For social, we want to do that full psychosocial assessment and refer him to somebody like social work or therapy or child life specialist if it's available at the hospital. Maybe arrange for teachers and friends to come and visit him. If he's not willing to reach out to them, maybe he'll allow them to visit. Possibly getting a tutor to come to the hospital and assist with his schoolwork, and refer the whole family to social work and support. For spiritual, we'd use the FICA tool or something similar just to ensure that we're capturing all of the information we need. We're going to refer Joe and his family to the chaplain or child life specialist, encourage his clergy or youth leader to visit, or maybe even his teachers or his soccer team or soccer coach if he's got a good relationship with them, and make plans for ongoing regular visits for those. For emotional, we're going to want to make sure we do screening for depression and anxiety, refer to psychiatry if indicated, and definitely move Joe to a private room off the adult ward as soon as possible, and consider anti-anxiety medications for the short term while we start to work through things. So you guys got pretty much all of that. So Kathleen's going to lead us through the second case study.
Oh, Jane. Jane has just finished her chemotherapy for metastatic lung cancer, which was found to have spread to nearby lymph nodes approximately 6 months ago. Her other diagnoses include arthritis to the bilateral knees, high blood pressure, and type 2 diabetes that is controlled by oral medication. She's a 55-year-old female who is single and lives alone in an apartment that she rents. She has smoked 1.5 to 2 packs of cigarettes a day before her diagnosis and was unwilling to quit at first, but managed to reduce her smoking to only half a pack a day over the last month. Jane has had a new job in a fast food restaurant before her diagnosis, but was let go when she couldn't continue working while undergoing her treatment. Jane has no children and has previously expressed that she is estranged from her family due to a history of abuse. Jane's best friend took a leave of absence from work to support her and drive her to appointments during her treatment, but has now returned to her own job. Jane was told last week after a follow-up CT scan that her treatment was not successful and that there was further evidence of disease in her ribs and spine. Jane arrives at the office via taxi for an appointment for a complaint of increasing pain in her back and knees, not relieved by her usual routine medication. Usually calm and good-natured, Jane gets upset with the reception staff upon arrival, yelling and cursing because appointments are running behind. Once her appointment begins, Jane becomes weepy and difficult to console. She tells you, "Everyone has abandoned me. It looks like no one has ever really cared about me. And what's the point of doing anything anyways?" But refuses to discuss it any further. So what are your initial thoughts on Jane's case? She's afraid, definitely. She doesn't have that support. She's depressed. Yeah, perfect. Where would you start your assessment with her? Yep, she might have regret as well. No support again. Yep. Single, lives alone. Her friend is unable to support at this time. So good physical pain assessment would be perfect. Yep. Thanks, Catherine. Any other assessments that have kind of creeped in the back of your mind? Financial assessment. Yep. She has no job anymore. She can't work. She on social assistance, disability, anything like that. Depression screening tool. Yep. Especially with the comments that she's made. Spiritual assessment. Yeah. Would you use open or closed-ended questions with this patient? Open. Perfect. And is she showing signs of total pain, would you say? Find out how she's sleeping. Good. Definitely. Yep. Absolutely. Perfect. So for those of you already incorporating a palliative approach to care for patients with a life-limiting illness, you're already on your way to addressing the treatment for total pain. So woo, we're getting there. So for Jane, you guys have mentioned a lot of this stuff. We would do that full pain assessment of both of her back and her knees, maybe do some imaging of the knees to rule out further metastases or other disease. We would have the intervention. We would use that WHO analgesic ladder for pain management, maybe a referral to orthopedics for specialized treatment, maybe a corticosteroid injection or surgery. We could do palliative chemo or radiation for the metastatic disease, again, to control and help with pain as well. For her social, we do the full psychosocial assessment, and interventions may include having that visiting hospice volunteer to come see her, a referral to social work, therapy, support groups, or put in a referral and application for practical supports, maybe have home care come in to support her, have light housekeeping if needed, transportation assistance as she was taking that taxi, and then just looking into her financial situation, which you have mentioned in those questions. For her spiritual, we would assess and use the FICA tool, like you said, or something similar. Again, incorporate that visiting hospice volunteer, referral to social worker chaplain. And for emotional, we would definitely want to screen her for depression and anxiety just based on some of the statements that she's made, make the referral to social work, therapy, or supportive counseling. So in summary, total pain requires a holistic approach involving physical, social, spiritual, and emotional realms. So just make sure that you're taking the time to kind of sit down and think about those questions when you are going in to see any of your patients. And that's it. If
These are
anybody
just some
has-
of our references.
you guys have any questions, feel free to use the chat, raise your hand, speak out.
Thank you so much. That was really, really well done. And I think that everyone really gathered what you're putting out, and then they brought it forward in the case study. So fantastic job, Kathleen and Laura. Thank you so much. I have put into
Thanks,
the chat,
Amanda.
I've put in the chat a few links. There is a copy of our YouTube playlist. So this will actually bring you to a point where it has all 5 sessions from the current series, as well as upcoming echo sessions with the network, as well as the survey link. All of these links will be included in the follow-up email that you will receive from Laura. And thanks again, ladies. And I hope everyone has a fantastic job. Fantastic job. Hope everyone has a fantastic day is what I meant to say. You all have fantastic jobs. So keep up the great work and have a good day.
Thank you, everybody.